Okay, let's unpack this. Today, we are taking a scalpel to a medical condition so incredibly common, yet whose underlying science and modern management techniques are often misunderstood. The abdominal hernia.
Hmm.
Forget the old stereotype of just a bulge from lifting something heavy. What we are diving into is, well, a pretty sophisticated story of anatomical compromise, genetic weakness, and surgical evolution.
Yeah, exactly. We need to see the abdominal wall not just as a container, but as a structure
Yeah.
constantly negotiating these conflicting demands. It requires incredible nonstop strength to hold everything in, right?
Yeah.
All that intra-abdominal pressure from just breathing, coughing, standing
Grab
up.
everything, yeah.
It also needs enough flexibility for movement, for changes like
Mm.
pregnancy, and it's that negotiation, that critical balance between strength and flexibility.
Right.
That's precisely where the weaknesses tend to arise.
Absolutely. So our mission today is to sort of distill the core concepts from the most advanced surgical sources out there. We want to really understand this trade-off. We want to know exactly what causes these defects,
Hmm.
how to tell the difference between, an inconvenience and a truly life-threatening complication, and maybe trace the revolution in repair techniques, from simple stitches to all this advanced mesh stuff.
Okay, so starting with a basic definition might help. An abdominal hernia is the abnormal protrusion, the pushing out
Mm-hmm.
of an organ or tissue through an opening in the layer that normally keeps it in place.
Right.
So in this case, we're talking about things pushing out from the inside, forcing their way through the abdominal wall, and they take the layers of peritoneum and fascia with them, creating that classic sac.
That concept of the abdominal wall structure is really fundamental, isn't it?
Yeah.
If you picture the body, the back is super strong. You've got the spine.
Solid.
The sides have these beautiful crisscrossing layers of muscle, the obliques, transverses.
Really well designed.
But the front, that's where it gets a bit simpler structurally and maybe more vulnerable.
Precisely. Up front, you basically have the two powerful vertical rectus abdominis muscles.
Yeah.
Your six-pack muscles. Right. And they're joined right down the middle by this strip of purely fibrous tissue called the linea alba.
The white line.
Exactly. That central vertical seam running from your breastbone down to the pelvis, it's naturally an area, let's say, tensile weakness.
Hmm.
And it's responsible for a lot of the hernias we see,
Hmm.
like epigastric or umbilical types.
Okay, but before we go further, we absolutely have to make a really critical clarification about that midline area, because lots of people confuse something else with a hernia there.
Yes, you mean devarication of the recti.
Exactly.
That's crucial. Devarication is simply the stretching and separation of the rectus muscles themselves. You see it a lot after pregnancy or sometimes in men with significant central obesity.
And it makes a bulge, right?
It does create a noticeable midline bulge, yeah.
Yeah.
But it's usually more of a fascial thinning rather than a distinct hole or defect with a contained sac. And, most guidelines now say it typically doesn't need surgical repair unless it's really causing symptoms or major structural problems.
Okay.
A true hernia, by definition, must involve a defined defect, an actual hole, and a sac coming through it, even if that sac only contains, say, extraperitoneal fat.
Got it. So understanding the cause of the true defect, the actual hole, goes way beyond just lifting heavy boxes then.
Oh, absolutely.
Our sources lay out 5 major causes, and they often seem interconnected, painting a much more, sophisticated picture of why this happens.
The first category is pretty fundamental, almost unavoidable. Anatomical weakness. These are areas that are just naturally compromised because they act as passages, right? Places where things need to enter or leave the abdomen during development or later.
Like the groin area.
Exactly. Prime examples are the inguinal canal, that's the path the spermatic cord or the round ligament takes. Then there's the femoral canal, lower down near the leg vessels. And, of course, the umbilical cicatrix, the belly button, where the umbilical cord used to be. These are just built-in weak spots.
Okay. And following closely on that are developmental failures.
Yeah, this is where something that should have closed up or disappeared during development just didn't.
Ah.
The classic result is the congenital indirect inguinal hernia. It's caused by the failure of the processus vaginalis to close completely. That's an extension of the peritoneum that follows the testes down.
Right, I remember that.
And if it doesn't seal off properly, it leaves this open pathway, basically a preformed hernia sac, ready for something to pop into years later.
And what's interesting is our understanding of why it fails to close is changing, isn't it?
It is, yeah. It's fascinating. We used to think it was purely mechanical, like a faulty zipper. But now, recent studies are pointing towards a hormonal influence, specifically involving substances like calcitonin gene-related peptide, and hepatocyte growth factor. These seem to control the successful sealing off of the processus vaginalis.
So if those hormones are off balance?
Exactly. If they're imbalanced or just not effective, the structure might stay open, leaving that natural pathway for a hernia.
Which leads us right into the third cause, and this seems like maybe the biggest shift in thinking about hernias recently. Genetic weakness of collagen.
This is huge. Yeah. This is where we really need to stop thinking of a hernia as just a hole that opens up and start seeing it as a sign of a more generalized structural weakness in the body's tissues.
So it's not just bad luck, it's bad building materials.
Kind of, yeah.
Mm-hmm.
Hernias are now fundamentally viewed by many as a sort of collagen disease.
Mm-hmm.
Collagen is the main scaffolding protein, right? It gives tensile strength to everything: skin, tendons, fascia.
Okay.
And histological evidence, looking at the tissue under a microscope, consistently shows that patients who develop hernias often have a defective ratio of collagen subtypes. Specifically, they tend to have less of the really strong type I collagen compared to the less resilient type 3 collagen in the fascia around the defect.
So the tissue itself is just subpar, even under normal pressure. Are there clinical links that back this up? Like, do people with known collagen issues get more hernia?
Absolutely. You look at people with known connective tissue disorders like Ehlers-Danlos syndrome. They have an incredibly high incidence of hernias. And beyond that, patients who show up with a hernia are statistically more likely to also have other problems linked to weak collagen. Things like aortic aneurysms or diverticular disease in the bowel. It suggests a widespread issue with the body's connective tissue matrix.
And this structural weakness can be made worse by lifestyle choices.
Definitely. The most obvious link here is smoking. Smoking actively impairs collagen maturation. It messes with an enzyme called lysyl oxidase, which is crucial for cross-linking collagen fibers properly. Without good cross-linking, the collagen matrix is weaker, less effective.
So smoking doesn't just make you cough and strain.
No, it's worse than that. It actively sabotages your body's ability to build and maintain strong connective tissue. It dramatically increases your lifetime risk of getting a hernia in the first place or having one come back after repair.
Okay, that's a really important point. The last two causes are maybe more intuitive, but still key: trauma or injury.
Yeah, and the main culprit here is previous surgery. We see incisional hernias coming through old scars in a staggering, 10% or even more of traditional open surgery scars, laparotomies.
Wow, 10%.
Yeah. Though modern keyhole surgery, laparoscopic ports, being much smaller, have a much lower rate, maybe around 1%. Rare blunt trauma can also cause them, but surgery is the big one.
And finally, aging and high pressure.
Right. Tissues naturally weaken a bit as we age. That's just degeneration. And this combines with any long-term excessive straining thing, chronic coughing from lung disease, severe constipation, problems urinating that cause straining. All that increases the pressure inside the abdomen. But, and this is a critical point, the sources emphasize the straining itself rarely causes a hernia in otherwise strong tissue.
It just reveals the weakness.
Exactly. It just applies the force needed to push the contents out through a weakness that was probably already there, bringing the hernia to the patient's and the doctor's attention.
Okay, let's shift gears now. Moving from why they happen to the clinical mechanics, the pathophysiology, and really the hierarchy of severity. How we go from maybe just a bulge to a genuine life-threatening emergency.
Right. So every hernia, doesn't matter if it's in the groin, the navel, or an old scar, it's defined by its basic components. You've got the defect, the hole in the wall, the sac, which is that outpouching of the abdominal lining, the peritoneum.
Okay.
And then the content that's pushed through the defect into the sac. And that content can be almost anything, really just fat, a piece of the omentum, that fatty apron in the abdomen, sometimes part of the bladder, or most worryingly, loops of small or large bowel.
And the single most important anatomical feature that dictates the risk level is the neck.
Absolutely. The neck is the narrowest part of the whole setup. It's right where the sac passes through the actual hole in the fascia, muscle layer, the signs of that neck, and maybe even more importantly, its rigidity determines everything. Well, think about it. A wide, flexible neck lets the contents slide in and out easily. No big deal usually. But a small, tight, rigid neck that acts like a bottleneck. A noose, really.
Okay, I see. And that rigidity and size is the basis for classifying how complex or how dangerous a hernia is, right? Starting with the safest state.
Yeah, the best case scenario is reducible. This means the contents, the bulge, move freely in and out of the defect. Often it disappears completely when the patient lies down and the pressure drops. This hernia is generally low risk, though it usually still needs dealing with eventually.
Okay. Then the next step up in severity is irreducible, or sometimes called incarcerated.
Right. Here, the contents are trapped. They're stuck in the sac, and you can't manually push them back into the abdomen. Now, this isn't necessarily an immediate surgical emergency, yet the blood supply might still be okay.
But the risk has gone way up.
Dramatically.
Yeah.
Because if the trapped content is bowel, the next stage is often obstructed. The gut lumen gets pinched off at the tight neck, causing a blockage, either partial or total.
And that causes classic symptoms.
Yeah, but the patient will usually present with classic bowel obstruction signs. Their abdomen gets distended, bloated, they start vomiting, they can't pass gas or stool. It's becoming urgent now.
And the real surgical emergency, the one where the clock is ticking loudest, is strangulated. Tell us what's happening physiologically when a surgeon hears that word.
Strangulation means the pressure at that tight neck is so severe that it has cut off the blood supply to the trapped contents. Specifically, the arterial blood flow is blocked.
Okay, so the tissue isn't getting oxygen.
Exactly. The tissue, whether it's a mentum or a piece of bowel, suffers ischemia, lack of oxygen and nutrients. If that pressure isn't relieved urgently, the ischemia rapidly progresses to infarction. That means tissue death, gangrene.
And if it's bowel?
If that necrotic dead bowel wall perforates, bursts, it spills highly contaminated infected bowel contents directly into the peritoneal cavity. That causes peritonitis, massive infection, sepsis, and unfortunately, a very high risk of death. It's about as serious as it gets in emergency surgery.
That really brings home the danger. And it leads us to a specific and kind of terrifying diagnostic twist that you often see with these tight neck defects. Richter's hernia.
Richter's. Yeah, this is a textbook example of how hernias can be diagnostically deceptive.
How so?
Well, in a typical strangulation, the entire circumference of the bowel loop gets trapped in the neck.
Right, pinching it completely shut.
Exactly, which leads to total bowel obstruction and those immediate obvious symptoms like severe pain and vomiting. But in a Richter's hernia, only a part of the bowel wall gets trapped, usually just a small knuckle on the side opposite the blood supply, the anti-mesenteric border.
So because the main channel of the bowel is still technically open.
Precisely. The patient might not experience the classic signs of a full obstruction. They might still be able to pass gas, maybe even have a bowel movement. They might just have some discomfort or mild intermittent pain.
So the doctor might be falsely reassured.
It's a real trap. The clinician is looking for those cardinal signs of obstruction and not seeing them. Meanwhile, that small, trapped piece of bowel wall is rapidly losing its blood supply. It's becoming necrotic, and it can still perforate locally, spilling contents and causing peritonitis, a life-threatening infection, but without the usual loud warning signals.
Wow. And these are common in which type of hernia?
They're particularly notorious in femoral hernias because those tend to have very small, very rigid necks.
Okay. We should also briefly touch on interstitial hernias because they don't quite fit the usual pattern either.
Right. These are a bit different. The hernia sac arises, and it's actually contained between the layers of the abdominal wall muscles themselves. It doesn't necessarily pop all the way out.
Like the Spigelian hernia we mentioned earlier.
Exactly. Small Spigelian hernias often behave this way. They might not produce an obvious external lump that you can see or feel easily. Diagnosis often relies purely on the patient reporting pain, maybe localized tenderness, and then getting imaging like a CT or ultrasound to actually see it burrowed between the muscle layers.
Got it. So, moving to how we diagnose these clinically. The history is often straightforward. Patient notices a lump, maybe an aching or heavy feeling, often worse at the end of the day or when they strain.
Yep.
But severe pain should always ring alarm bells for strangulation risk. The physical exam, though, that's critical, starting with the famous cough impulse.
Yeah, the standard exam involves having the patient stand up and cough or bear down like they're straining the Valsalva maneuver. This increases the pressure inside the abdomen. If you see or feel the swelling clearly get bigger, more prominent, and maybe feel a bit softer or tenser as they cough, that's an expansile cough impulse.
And that usually means?
It strongly suggests a reducible hernia. The contents are being pushed out further by the pressure. If that impulse is clearly present, the diagnosis is often pretty straightforward.
However, our sources really hammer home this crucial diagnostic paradox that can easily trip up clinicians, especially less experienced ones.
Yeah, this paradox is really important to understand, and it has two parts. First, just because a swelling has a cough impulse doesn't automatically mean it's a hernia.
Oh, what else could it be?
Well, things like a saphenous varix, that's a varicose swelling at the top of the main leg vein, can also swell with coughing due to back pressure, or even an aneurysm in the femoral artery. So Cough impulse present doesn't equal hernia, always.
Okay. But the second part of the paradox is the more dangerous one, isn't it?
Much more dangerous.
Hmm.
A swelling with no cough impulse might still be a hernia. In fact, it might be one of the most dangerous kinds.
That seems totally counterintuitive. If the pressure inside goes up, why wouldn't the hernia bulge out more?
Because the neck is already so tight and rigid. Think of that noose analogy again. The moment the hernia contents push through that tight ring, the pressure effectively locked them in place. The extra pressure from the cough can't force the contents any further out because they're already maximally constricted. So this finding a firm, maybe slightly tender lump, often small, that lacks an expansile cough impulse is highly characteristic of those really dangerous tight-necked hernias, especially femoral hernias.
And that's why they get missed.
Exactly. It feels like a firm little lump, maybe like a lymph node. It doesn't bulge when they cough.
Yeah.
It's so easy to misdiagnose it as something benign, like an enlarged gland, and that delay can be absolutely catastrophic if it's actually a strangulating femoral hernia.
Wow. Okay. So the crucial checks during the exam have to be really thorough then. You need to assess if it's reducible, check carefully for any tenderness, look for skin changes like redness or warmth, suggesting inflammation or ischemia,
Definitely. Any sign of skin change is an emergency.
and always check the other side, the contralateral side.
Always. Because occult, or hidden hernias on the other side, are surprisingly common. You might find one in up to 20% of patients presenting with a groin hernia on one side. Helps with planning the surgery, too.
Right. So what if the diagnosis is still uncertain after history and exam, or if it seems like a really complex case? That's where imaging comes in.
Correct. While most straightforward hernias are diagnosed clinically, imaging is invaluable for tricky cases. Ultrasound is usually the first go-to. It's low cost, readily available, uses no radiation.
And what's it good for specifically?
It's great for irreducible hernias. It can help figure out what's trapped inside. Is it fluid, like a post-op seroma? Is it a solid mass? Is it actually bowel loops? It's also good for differentiating a hernia from other lungs, like a hydrotule and a large lymph node, or that saphenous varix we mentioned. And post-operatively, it's useful for telling an early fluid collection from a true recurrence.
But it has limitations.
The main one is that it's highly operator dependent. The quality of the scan and the interpretation really depends on the skill of the person doing it.
Okay. Then for the really big, complex abdominal wall problems, especially those incisional hernias after previous major surgery, the CT scan becomes essential.
Yeah, for complex ventral and incisional hernias, the CT scan is basically the surgeon's roadmap. It's indispensable for preoperative planning.
What does it show you?
It gives you incredible detail. You can map the exact size and location of all the fascial defects. Sometimes there are multiple holes. You can see exactly what contents are in the hernia sac, identify any adhesions sticking bowel to the sac or the abdominal wall. It helps rule out other problems, like maybe an underlying tumor causing the bulge. And crucially, it helps the surgeon plan the reconstruction, figure out how much mesh they'll need, where it needs to go, whether they can close the fascia or need to bridge the gap.
Makes sense. And finally, there's MRI. It seems to have a more niche but still important role.
MRI's strength is its superior soft tissue detail. So its main niche in the hernia world is diagnosing that tricky condition often called sportsman's groin or Gilmore's groin.
Where there's pain but no obvious lump.
Exactly. It's chronic groin pain, often in athletes, without a clear external hernia bulge. The MRI is the best tool we have to distinguish a very subtle, hidden, or occult hernia from other causes of groin pain, like orthopedic issues, tears in the rectus muscle insertion, adductor tendon strains, hip joint problems. They can all present very similarly.
And what about using laparoscopy itself, keyhole surgery, for diagnosis?
Laparoscopy can be useful diagnostically, yeah. Especially if you're already operating on one side for an inguinal hernia, you can take a look at the contralateral side to check for a hidden defect there. Or, before a complex incisional repair, a diagnostic laparoscopy can help assess the inside, see how bad the adhesions are, if a laparoscopic approach is even feasible.
But it has blind spots.
The main one is that it won't see those interstitial hernias, like the Spigelian type, that are hidden between the muscle layers because you're looking from the inside out.
Okay, we have a good handle on the anatomy, the risks, the diagnosis. Let's turn to management. And the first really core principle established by modern practice is that the decision isn't always operate versus don't operate. Sometimes it's operate versus watchful waiting.
Exactly. Watchful waiting is now a perfectly safe and accepted strategy for very specific patient groups and hernia types.
Who qualifies?
Primarily, This applies to early, minimally symptomatic, or even asymptomatic inguinal hernias, especially in older patients, maybe with other health problems, where the risks of anesthesia and surgery might actually outweigh the relatively low immediate risk of the hernia itself causing a problem.
How often do those patients end up needing surgery anyway?
Studies show that roughly 10% of patients managed with watchful waiting for an inguinal hernia will eventually cross over and opt for surgery each year, usually because the symptoms gradually worsen or become bothersome.
Okay. Any other hernias where waiting is okay?
Yes. Also small umbilical or epigastric hernias that clearly only contain fat or omentum, not bowel. Because the risk of strangulation for those is very low, conservative management is often reasonable, especially if the patient prefers to avoid surgery.
But then there are clear situations where waiting is absolutely not an option, right?
Definitely. Immediate repair is considered mandatory for all femoral hernias, period, because that strangulation risk is just unacceptably high, as we discussed.
Okay.
And beyond that, any hernia that becomes acutely symptomatic, meaning sudden onset of pain, rapid enlargement, or critically, any hernia that becomes irreducible, that gets stuck, that needs prompt scheduling for repair. You can't wait on those.
And what if the patient presents as an acute emergency? That painful, irreducible lump we talked about suggesting strangulation.
That is a surgical emergency, plain and simple. Urgent surgery is required, usually within hours, to get in there, relieve the pressure at the neck, and, most importantly, assess the viability of the trapped tissue. See if it's still alive or if resection is needed.
Can you try to push it back in first?
Sometimes, yeah. Gentle manual reduction, called taxis, might be attempted in the emergency department. Sometimes giving strong painkillers helps relax the patient and the muscles, making reduction possible. But even if you successfully reduce it,
Surgery is still needed.
absolutely, the fact that it got stuck once means the neck is tight, and the risk of it happening again and potentially strangulating next time is very high. So, even after successful taxis, surgery should still be scheduled relatively soon afterwards to fix the underlying defect definitively.
Okay, that makes perfect sense. Now let's dive into the most common type of hernia overall, the inguinal hernia. This is really where surgical history and modern techniques have seen the most dramatic evolution.
It really is the classic hernia.
Yeah.
And understanding the inguinal canal anatomy is key.
Yeah.
We have to distinguish between the two main types based on where they start relative to the inferior epigastric blood vessels.
Right. First, the indirect hernia, sometimes called lateral or oblique. This is the one linked to that developmental failure we mentioned earlier.
Exactly. It's considered congenital in origin, even if it doesn't show up until adulthood. It arises because the processus vaginalis didn't close, so the hernia sac enters the inguinal canal through the deep inguinal ring, which sits lateral to those inferior epigastric vessels.
And it follows that path downwards.
Yep, it follows the long, oblique path of the spermatic cord in men, or the round ligament in women. And because it's following this preformed pathway, it can potentially travel a long way, descending deep into the scrotum or labia, sometimes becoming a really massive scrotal hernia.
Okay. Then the other type is the direct hernia or medial.
Correct. The direct hernia is always acquired. It's not from a developmental failure. It's caused by weakness, stretching, and degradation of the tissues forming the back wall of the inguinal canal itself. Specifically, it pushes through an area called Hesselbach's triangle.
And where's that located?
Hesselbach's triangle is medial to the inferior epigastric vessels. Its borders are the edge of the rectus abdominis muscle medially, the inguinal ligament below, and those epigastric vessels laterally.
And because it's punching straight through the wall there.
Right. It's usually a broader-based bulge, not following a narrow track. And because of that broader base, direct hernias are generally less likely to strangulate compared to indirect ones. The neck tends to be wider.
That's interesting. And there was a point about the bladder being involved sometimes.
Yeah, that's relevant mainly for direct hernias. Because the urinary bladder sits quite close to the medial side of Hesselbach's triangle, as a direct hernia enlarges, it can sometimes pull part of the bladder wall into the hernia sac along with it. Surgeons need to be aware of that possibility during repair.
You mentioned earlier the classic exam technique to try and tell them apart, pressing on the deep ring.
Yes, the traditional test. You find the midpoint of the inguinal ligament, that's roughly where the deep inguinal ring is located internally. You place your thumb or fingers firmly there to occlude it. Then you ask the patient to cough again. If the hernia bulge is controlled, meaning it doesn't pop out when they cough with your finger pressing, it suggests the hernia is coming from the deep ring, so it's likely indirect. If, however, the bulge still appears medial to your pressing finger when they cough, it suggests it's punching directly through Hesselbach's triangle, so it's likely direct.
But it's not always that clear cut.
Honestly, no. Even experienced surgeons often admit it can be difficult to be 100% certain based on exam alone. You often only know for sure once you're actually operating,
Yeah.
but it's the classic teaching.
Okay. Now, let's talk about the evolution of how we fix these. For decades, the entire field was dominated by suture repair, wasn't it? Also called herniorrhaphy.
Absolutely. And the key concept, or maybe the key problem with suture repair, was tension.
Right.
The real foundation of modern hernia surgery was laid by Eduardo Bassini way back in 1890. His repair basically involves stitching different layers of the patient's own tissue together, often pulling the conjoint tendon down to the inguinal ligament to try and reinforce that weak posterior wall. It was revolutionary for its time. But it still relied entirely on suturing inherently weak, often compromised native tissue to other native tissue, and doing it under significant tension. Pulling those tissues together created tension along the suture line.
And that tension inevitably led to problems, like the hernia coming back?
Exactly. High recurrence rates were the major drawback of most traditional suture repairs because the sutures would eventually pull through the weak tissue or the tissue would just stretch out again under pressure.
How did the famous Schultes repair try to improve on that? I hear that name mentioned a lot.
The Schultes repair, developed at the Schultes Clinic in Canada, was a very meticulous, specialized suture technique. It focused intensely on creating multiple layers of reinforcement using the patient's own transversalis fascia.
How did they do that?
It involved very careful dissection and then essentially double-breasting the fascia, creating a two-layered overlapping closure, sometimes even more layers, with fine, continuous sutures. In the hands of surgeons at specialized centers like Schultes,
The results were good.
the results were incredibly good.
Yeah.
Recurrence rates were very low, sometimes even rivaling what we see with modern mesh techniques. But the big catch was that it was exquisitely technically demanding. You had to be really skilled and do it exactly right. And fundamentally, even though it distributed tension better, it was still placing sutures under some tension across tissue that was, by its nature, prone to weakness. Another suture technique was the Maloney darn, using a continuous back-and-forth stitch like darning a sock.
So outside of those highly specialized centers, the tension problem and the resulting high recurrence rates persisted, and that failure is really what paved the way for the mesh revolution, wasn't it? Specifically with the Liechtenstein tension-free repair emerging in the 1980s.
Absolutely. The Liechtenstein repair marked a complete paradigm shift, a fundamental change in philosophy. Instead of trying to pull weak tissue together under tension, Dr. Liechtenstein's idea was brilliantly simple. Just bridge the weak area. Place a patch over the hole. A flat sheet of synthetic material, usually polypropylene mesh, is placed over the weakened posterior wall of the inguinal canal, covering the defect entirely.
And crucially, without pulling the native tissues together.
Exactly. It's secured lightly at the edges, but the mesh itself bears the load, reinforcing the area without creating tension on the surrounding tissues. This simple concept, tension-free repair, caused recurrence rates to plummet dramatically, down into the low single digits, like 1–2%. And because it's relatively straightforward to learn and perform consistently, it remains the most common open hernia operation performed worldwide today.
But the story doesn't end there. The last, say, 20 years or so have seen the rise of laparoscopy as an equally important, maybe even preferred for some situations, advancement, especially for inguinal hernias. We hear about TEPI and TPP approaches.
Right. TEP stands for totally extraperitoneal repair, and TAPP is transabdominal preperitoneal repair. Both are minimally invasive techniques done through small keyhole incisions.
And what's the core goal they share?
The fundamental goal for both TP and TPP is the same. The surgeon works from the inside, reduces the hernia contents back into the abdomen, and then places a very large piece of mesh, much larger than in the open Liechtenstein repair, often 10 by 15 centimeters or even bigger, into a specific space called the preperitoneal plane.
Okay, the preperitoneal plane. Why is placing the mesh deep in that space, behind the abdominal muscles, considered so mechanically advantageous?
It comes down to harnessing the body's own pressure. It's sometimes called the principle of pneumatic stability. Think about the constant positive pressure inside your abdomen pushing outwards.
Yeah.
If you place mesh on the surface of the muscle, an onlay, that internal pressure is constantly trying to push the mesh off. But if you place the mesh deep in the preperitoneal space behind the muscles, a sublay or extraperitoneal placement, that same internal pressure now works for you. It pushes the mesh against the back of the abdominal wall, pressing it firmly over the defect, sort of locking it into place.
Like an internal patch held on by pressure.
Exactly. And because the pressure helps hold it there, it dramatically reduces the need for aggressive fixation with sutures or tacks, which in turn minimizes the risk of irritating or injuring nerves in that area.
Okay, that's clever. And the sources consistently highlight some clear benefits for the patient with laparoscopic repair compared to open Liechtenstein, right? Like pain.
Yes, the data is pretty consistent now. Laparoscopic repair generally leads to significantly less postoperative pain, not just in the first few days, but studies have tracked this benefit out to 5 years or more after surgery.
And getting back to normal life.
Much faster return to normal activities and work, often within a week or two, compared to several weeks after open surgery.
And are there specific situations where laparoscopy is particularly recommended?
It's considered especially advantageous for patients who have hernias on both sides, bilateral hernias, because you can repair both through the same small keyhole incisions in one operation. It's also often the preferred approach for patients who have a recurrence after a previous open suture or mesh repair, because you're coming in from a different angle through fresh tissue planes, avoiding the scar tissue from the first operation.
Okay. But, and there's always a but in medicine, it seems. The success of modern repair, whether open or laparoscopic, is now being judged by a new metric. Recurrence isn't the main worry anymore, it's chronic pain.
That's absolutely right. Chronic pain, usually defined as pain, discomfort, or numbness in the groin area that lasts longer than 3 months after the surgery, has really become the modern scourge of hernia repair. It affects a significant minority of patients. Figures vary, but up to 20% report some level of chronic symptoms after certain types of groin hernia repair.
20% is huge.
It is. So the focus for surgeons has shifted dramatically. It's no longer just about plugging the hole and preventing recurrence. It's equally, if not more, about preserving the patient's long-term quality of life and preventing this debilitating chronic pain.
Why does this pain happen? What's causing it? And why does it seem to be less common, or at least less severe, after laparoscopic repair compared to open?
Most significant chronic groin pain after hernia surgery is neuralgic pain. It's caused by irritation, entrapment, or sometimes direct injury to the 3 main sensory nerves that run through the inguinal canal and surrounding area: the ilioinguinal nerve, the ilioepigastric nerve, and the genitofemoral nerve, specifically its genital branch.
And how do the different surgeries affect these nerves?
Well, in traditional open repairs, like the Liechtenstein, the dissection happens right in the inguinal canal, very close to where these nerves run. They can be inadvertently cut, stretched, trapped by a suture used to fix the mesh, or compressed by the mesh itself or the resulting scar tissue.
Okay.
In laparoscopy, TAP or TAPP, the mesh is placed much deeper in that peritoneal space behind the muscles. While the nerves are still nearby, the dissection plane is often further away from the main trunks, and critically, as we said, less fixation is usually needed. This generally means less chance of direct nerve injury or entrapment.
So the surgical guidelines for laparoscopy must really emphasize nerve avoidance in that deep space.
Oh, absolutely. Modern training and guidelines strongly caution surgeons against placing staples or transfixing sutures for mesh fixation in certain danger zones in the deep peritoneal space, precisely because the known paths of these nerves run there. The whole strategy has shifted from just closing the defect to meticulously identifying and preserving nerve function whenever possible. It really shows how patient-reported outcomes and quality of life have taken center stage.
Okay, that's a perfect transition. Since modern hernia repair is so defined by the materials we use, let's dedicate a proper deep dive specifically to mesh technology. Because it's not just a simple piece of plastic, is it? It's really an engineered biological interface.
That's a great way to put it, yeah. Mesh is essentially a scaffold. Its one and only purpose is to reinforce the weakened abdominal wall and, crucially, to provoke a localized, controlled foreign body reaction.
A foreign body reaction, you want that.
You do, a controlled one. The body recognizes the mesh as foreign and initiates an inflammatory response, leading to fibroblasts laying down collagen and forming scar tissue that grows into the pores of the mesh. It's this scar tissue integration that provides the long-term strength and drastically reduces the chance of the hernia coming back.
Okay. And we already talked about the mechanical advantage of placing it deep, in the sublay extraperitoneal plane, where abdominal pressure helps lock it in place.
Right. That's generally the preferred plane whenever possible for both open and laparoscopic repairs, because it harnesses Pascal's law: pressure is transmitted equally, pushing the mesh against the wall. Other placements exist, like onlay on top of the muscle fascia, but that's less mechanically sound and has higher risks of exposure or infection. And then there's intraperitoneal, which we need to discuss carefully.
Before we get to intraperitoneal, let's talk materials. The vast majority of mesh used worldwide is synthetic, right?
Yes, overwhelmingly. The main players are polypropylene, polyester, and sometimes PTFE, which you might know as Teflon. Polypropylene is probably the most common. Relatively inert, it's hydrophobic, doesn't absorb water, it's quite flexible, and it reliably elicits that scar tissue ingrowth we need.
But the story of mesh development wasn't straightforward. You mentioned early meshes were over-engineered, the heavyweight kind.
Yeah, the first generation of meshes, particularly polypropylene, were quite thick, dense, and had very small pores. They were incredibly strong, probably much stronger than biologically necessary.
And what was the problem with that density and weight? What did it do biologically?
The problem was they provoked a massive, overly aggressive foreign body reaction. The body saw this dense, heavy material as a major invader and basically tried to wall it off with incredibly thick, stiff, dense scar tissue.
And that stiffness caused issues.
Two major ones. First, the area just felt stiff and unnatural to the patient. But more significantly, it led to the phenomenon known as mesh contracture.
Okay, let's clarify that term. Because people often think the plastic mesh itself is shrinking like a wool sweater in the wash. Is that what happens?
Not really, no. The plastic mesh itself is pretty stable dimensionally. The contracture is actually the dense, fibrous scar tissue that grows into the mesh pores. That scar tissue matures and naturally contracts over time, sometimes significantly.
How much can it contract?
Studies have shown that dense scar formation around heavyweight, small pore mesh can reduce the effective surface area of the mesh by as much as 30 to 50% over months or years.
Wow. And what does that lead to?
It leads to that feeling of stiffness, a chronic foreign body sensation, I can feel the mesh, and often chronic pain. And if the contracture is uneven or pulls the mesh away from the edges where it was secured, it can actually lead to a recurrence of the hernia, even though the mesh material itself hasn't failed.
So the realization dawned that maybe less is more. We needed something strong enough, but more flexible, more natural feeling.
Exactly. That led to the development and current preference for large pore, lightweight mesh. The idea is to use less material overall, make it more flexible, and critically have larger pores, typically at least 1 millimeter in diameter.
And what do the larger pores do?
They allow for a more organized, less aggressive tissue ingrowth. You get thinner, more flexible scar tissue bridges forming across the pores rather than a solid, dense plate of scar. This theoretically leads to a more elastic repair that integrates better with the natural abdominal wall, causing less stiffness and less pain. That's the current standard of care.
Okay. Now we have to tackle the really complicated issue. Placing mesh intraperitoneally, IPOM. That means putting it right inside the abdomen, directly touching the bowel and other organs.
Right. And standard polypropylene mesh, stuff used for Liechtenstein or TEP-TPP, absolutely cannot be placed there.
Why not?
Because bare polypropylene is highly thrombogenic and inflammatory when it touches bowel or omentum. It will immediately induce aggressive, dense adhesion formation. Loops of bowel will stick to it like glue.
Which can cause blockages later.
Precisely. Adhesive small bowel obstruction is a major risk. Therefore, if the surgical approach requires the mesh to be placed inside the peritoneal cavity, which is common in laparoscopic repairs of ventral or incisional hernias, surgeons must use specialized tissue-separating meshes, sometimes called composite or barrier meshes.
Okay, so these are special meshes with two different sides.
Exactly. They're engineered with two distinct surfaces. One side, facing the abdominal wall, is usually porous, maybe like lightweight polypropylene, designed to encourage that necessary tissue ingrowth for fixation. The other side, the one that will face the bowel and organs,
Needs to be slippery.
needs to be non-adherent. It's usually coated with some kind of absorbable barrier materials like oxidized regenerated cellulose, collagen, hyaluronic acid, or sometimes a permanent non-stick layer like expanded PTFE, EPTFE. The goal is to provide the reinforcement against the abdominal wall while preventing the viscera from sticking to the inner surface.
But even with these advanced, often very expensive composite meshes, placing anything intraperitoneally still carries inherent risks, doesn't it?
Absolutely. No barrier is 100% perfect or foolproof forever. IPOM placement, even with the best composite meshes, is still associated with a higher risk of complications compared to placing mesh outside the peritoneum.
Such as?
Such as, well, still some risk of adhesions forming eventually, potentially leading to bowel obstruction years down the line. Chronic pain can also be an issue, sometimes related to the tacks or sutures used to fix these meshes quite firmly to the peritoneum. And in rare, really catastrophic cases, there have been instances of the mesh eroding through the bowel wall over time, causing a fistula, an abnormal connection between the bowel and the skin or another organ.
So the preference is still to avoid IPOM if possible.
Generally, yes. Most surgeons who specialize in complex abdominal wall reconstruction try to achieve a sublay or extraperitoneal mesh placement whenever technically feasible, precisely to avoid the long-term risks associated with having mesh in direct contact with the bowel. IPOM is often reserved for situations where the defect is so large or scarred that a deep placement just isn't possible.
Okay. And finally, the universal Achilles heel for any synthetic mesh, regardless of type or placement, infection.
Yeah, mesh infection is a disaster.
Mm.
If bacteria get onto a synthetic mesh, especially during or soon after surgery, the porous material essentially provides a safe harbor for them. It becomes a biofilm nidus,
And antibiotics can't clear it.
often not effectively, because the bacteria are hiding within the mesh structure, shielded from systemic antibiotics and the body's immune cells. In most cases, once a synthetic mesh becomes truly infected, the only definitive cure is to remove the entire piece of mesh surgically.
Which must be a huge operation.
It's a major undertaking. It often means undoing the entire previous repair, dealing with infected tissues, and it immediately leaves the patient with the original defect, often larger and more difficult to repair later, usually requiring complex tissue flap reconstructions rather than just putting in another piece of mesh right away. It's a complication surgeons work very hard to avoid through sterile technique and sometimes antibiotic prophylaxis.
That covers synthetic mesh really well. What about biological mesh? We hear about that sometimes, derived from human or animal tissue.
Biological meshes are an interesting and still evolving area. They're derived from decellularized tissue, meaning the cells are removed, leaving just the collagen scaffold, often from human dermis, skin, porcine, pig, dermis, or bovine cow, pericardium, heart sac.
And what's the theory behind using them?
The idea is that they provide a natural scaffold that the patient's own cells can infiltrate and remodel over time. Theoretically, the biological mesh gradually gets broken down and replaced by the patient's own new tissue, leaving behind a reinforced area without a permanent foreign body.
So potentially fewer long-term issues like chronic pain or infection.
That's the hope, and why they're often considered in specific complex situations, particularly in contaminated fields where putting in a synthetic mesh would be asking for trouble, or maybe in reconstructing very large defects. However,
There's always a however.
yeah, biological meshes are extremely expensive compared to synthetics, and the evidence on their long-term durability is still mixed. Some studies show they might stretch out or degrade too quickly, leading to higher recurrence rates than synthetic mesh in clean, straightforward repairs.
Yeah.
Their exact role is still being defined, but they're a valuable option in certain challenging scenarios, especially where infection is a major concern.
Okay, let's just focus again. We've covered inguinal hernias and mesh in detail. Let's dedicate some time now to the other common and sometimes high-risk hernia types, moving away from the groin. Starting with ventral hernias, that group including umbilical, epigastric, and the rarer Spigelian types.
Right. The umbilical hernia in adults is extremely common. We see it strongly associated with conditions that cause chronically increased intra-abdominal pressure.
Like what?
Multiple pregnancies are a big one, significant obesity, and quite severely, liver cirrhosis that leads to ascites that's the accumulation of large amounts of fluid in the abdomen, which really stretches the abdominal wall.
Clinically, you mentioned umbilical hernias can be deceptively risky. Why is that, even if they look small?
It's again down to the neck. The defect in the linea alba right at the umbilicus, the belly button scar tissue, is often quite narrow and very fibrous, very rigid.
Like the femoral canal.
Similar principle, yeah. That small, rigid opening makes adult umbilical hernias highly prone to getting incarcerated, stuck, and then strangulating. They really shouldn't be ignored or just watched indefinitely if they contain bowel or are symptomatic.
And the management principles here really highlight how suture repair alone has largely failed, even for these midline defects.
Absolutely. Historically, surgeons used techniques like the Mayo repair, sometimes called the vest over pants, or waistcoat over trousers repair, where they'd overlap the fascial edges and suture them. It was popular for defects up to maybe 2 centimeters.
But it didn't hold up.
The recurrence rates, especially for anything larger than a tiny defect, say less than 1 centimeter, proved to be unacceptably high with suture closure alone. The tension on the repair was just too much for the linea alba.
So mesh is now the standard.
Pretty much. Current consensus and guidelines strongly advise using mesh reinforcement for virtually all umbilical hernia defects larger than 1 to 2 centimeters in adults. It significantly cuts down the recurrence rate. Even for smaller ones, many surgeons now prefer mesh.
Can these be repaired laparoscopically?
They can, yes. Laparoscopic umbilical hernia repair is quite common. However, it often involves placing the mesh intraperitoneally, IPOM, using one of those composite meshes we discussed.
Bringing those associated risks back into play.
Exactly. While laparoscopy might offer benefits like smaller incisions and maybe faster recovery for some, it does introduce the potential long-term risks of IPOME and placement adhesions, maybe chronic pain from the fixation tacks, into what could otherwise be a relatively straightforward open repair with the mesh placed deeper in a sublay or preperitoneal position. So there's a trade-off to consider there.
Okay. Next up, the epigastric hernia. Where do these occur?
Epigastric hernias also arise through small defects in that midline linea alba, but they occur above the umbilicus, somewhere between the belly button and the xiphoid process, the bottom tip of the breastbone.
And what's usually inside them?
Typically, they only contain extraperitoneal fat, just a little knuckle of fat pushing through the hole, rarely bowel.
But these can be really painful, can't they? Even if the lump itself is tiny.
Yes, they're often deceptively painful. The patient might complain of quite severe, sharp, localized pain, even when the palpable defect is minuscule, like the size of a fingertip.
Why so painful?
It's thought to be because that small plug of fat gets chronically nipped or pinched at the sharp, fibrous edge of the fascial defect. It might undergo partial strangulation or ischemia, causing significant pain, even though it's not bowel.
And how are they repaired?
The principles are similar to umbilical repair. Small ones might be sutured, but mesh is generally preferred for anything larger than 1 centimeter, or if pain is a major feature, to prevent recurrence. A really crucial point for the surgeon operating on epigastric hernias is to actively look for multiple defects.
Oh, they often come in clusters.
Very often, yeah. It's common to find 2 or 3 small defects quite close together along the linea alba. If the surgeon only fixes the one that seems most obvious and misses the others, the patient will inevitably come back complaining of a recurrence when actually it was just an adjacent defect that was missed the first time. Thorough exploration is key.
Good point. Okay, and finally in this ventral group, the really elusive one, the Spigelian hernia. These sound tricky.
They are tricky. Spigelian hernias are relatively uncommon. They arise through a specific weak spot in the abdominal wall called the Spigelian fascia. This is the aponeuroses, a sheet of fibrous tissue, of the transversus abdominis muscle, specifically where it lies lateral to the edge of the rectus abdominis muscle, usually in the lower abdomen.
And why are they so hard to diagnose? You said they're often hidden.
Exactly, because the hernia sac pushes through the transversus abdominis and internal oblique layers, but the outermost layer, the external oblique muscle and its aponeurosis, often remains intact, covering the hernia.
So it bulges between the muscle layers.
Yes, it's a classic example of an interstitial hernia. The bulge isn't always palpable or visible externally.
Yeah.
The patient might just present with intermittent localized pain, maybe a vague tenderness in that area.
So diagnosis usually needs imaging.
Almost always relies on imaging, yeah.
Yeah.
A targeted ultrasound or, more definitively, a CT scan is usually required to confirm the diagnosis and show the sac nestled between the muscle layers.
And are these dangerous? Do they need fixing?
Yes, surgery is generally recommended once a Congenital hernia is diagnosed, because the defect through the spigelian fascia is often quite narrow and has sharp, rigid edges. The risk of incarceration and strangulation is considered significant, much higher than for, say, a direct inguinal hernia. They shouldn't be left untreated.
Okay, that covers the ventral group. We absolutely must now focus specifically on the 2 categories often considered the highest risk: femoral hernias and incisional hernias. Let's start with femoral hernia. You've described it as perhaps the most dangerous lump someone can find.
It really is up there, a true surgical time bomb. As we said, it's less common overall than inguinal hernias, maybe about 5% of all groin hernias. It's classically seen more often in women, particularly thin elderly women, but men can get them too. And it arises through the femoral canal.
Where exactly is that?
The femoral canal is a potential space located in the upper thigh, just below the inguinal ligament. Crucially, it lies medial to the large femoral vein, so it's very close to major blood vessels.
And the terrifying statistic you mentioned earlier needs repeating. Something like 50% of femoral hernias present for the first time as a surgical emergency.
That's the chilling statistic, yes. Around half will present acutely with incarceration or strangulation. The risk is just catastrophically high.
Why? What makes that specific spot so incredibly dangerous?
It comes down entirely to the rigid, unyielding anatomy surrounding the femoral canal. Think of it like a tiny, triangular tunnel with rock-hard walls.
What are the walls?
Its posterior border is bone, the pubic bone, pectineal ligament. Its lateral border is the firm wall of the femoral vein. And its medial border, this is the real killer, is the sharp, unyielding, almost knife-like edge of the lacunar ligament, which is also called Gimbernaut's ligament.
So when bowel pushes into that space,
When bowel or omentum is forced through the narrow entrance into the femoral canal, that sharp lacunar ligament acts as an immediate, non-negotiable constricting band. It guarantees rapid compromise of the blood supply. There's just no give.
and this feeds directly back into that diagnostic paradox we discussed earlier, making them easy to miss.
Absolutely. Because the neck is intrinsically small, sharp, and rigid, the hernia itself is usually small, maybe only 1 or 2 centimeters in diameter. It quickly loses any expansile cough impulse because it gets locked in. And critically, it's located below the inguinal ligament in the upper thigh groin crease area.
So it doesn't look like a typical groin hernia.
Not like an inguinal hernia, no. It's lower down. And because it's small, firm, and doesn't bulge with coughing, it is constantly tragically mistaken for something benign, like a slightly enlarged lymph node or a small fatty lump, lipoma. This misdiagnosis leads to critical delays in treatment, which can cost the patient their bowel or even their life.
So given that extreme risk, the rule is mandatory urgent surgery for all confirmed femoral hernias. No watchful waiting here.
Absolutely non-negotiable. Once a femoral hernia is diagnosed, it needs surgical repair, typically with some urgency. Even if it seems reducible at that moment, you just can't risk waiting for it to strangulate.
And if it does present as an emergency, already strangulated, what's the preferred surgeon's approach? You mentioned a high approach.
Yes. In an emergency setting, most surgeons prefer a high approach, like the McCavity or Nyquist modification. These techniques involve making the incision higher up, above the inguinal ligament, and approaching the femoral canal from the abdominal side.
Why is that better in an emergency?
Because it gives the surgeon much better access and control. They can safely identify and release the constricting lacunar ligament from above, reduce the hernia contents back into the abdomen, and then crucially gain wide access to the peritoneal cavity to properly inspect the viability of the bowel. If a segment of bowel looks dead or compromised, gangrenous, they have the access needed right there to perform an immediate bowel resection and an anastomosis, rejoining the bowel.
Whereas simpler approaches from below don't allow that.
Correct. Simpler low approaches like Lockwood's incision made directly over the lump in the thigh might allow you to fix the hernia, but they don't give you adequate access to inspect the bowel inside the abdomen or perform a resection easily if needed. The high approach is much safer in an emergency.
Okay, that's very clear on femoral hernias. Now let's talk about the other major high-risk category, incisional hernias. These are the ones that arise through old surgical scars. They sound incredibly common.
They are depressingly common. The reported incidence varies wildly in the literature, depending on the type of initial surgery, patient factors, and how long they're followed up. But it can be anywhere from 10% to as high as 50% following a major open abdominal operation, especially a midline laparotomy.
50%? That's enormous.
It is. It represents a huge burden of repeat surgery and morbidity. So the modern focus here is really twofold: prevention in the first place, and then effective reconstruction when they do occur.
What does prevention look like now? How do surgeons try to stop these from happening after the initial operation?
It centers almost entirely on improving the technique used to close the fascia, the main strength layer of the abdominal wall, at the end of the first operation. We now know that the way the stitches are placed matters hugely.
How so?
Surgeons are now trained in, and guidelines recommend, the small stitch, small bite closure technique. This involves using a slowly absorbable or non-absorbable suture, taking small bites of the fascial edge, maybe 5-8 millimeters back from the edge, and placing the stitches close together, around 5 millimeters apart.
Why is that better than big stitches further apart?
It distributes the tension much more evenly along the entire length of the closure. Big stitches placed far apart concentrate the stress at each suture point, making it more likely for the suture to pull through the fascia, or for the fascia between the sutures to tear, like tearing along a perforated line. The small bite, close together technique creates a more secure, less tension closure.
Are there other prevention strategies?
Yes, there's also an increasing trend, supported by some good evidence, toward placing prophylactic mesh during the initial operation in patients deemed very high risk for developing an incisional hernia later.
Who would be high risk?
Patients who are significantly obese, those with previous hernias, maybe smokers, diabetics, or anyone undergoing emergency surgery where tissue handling might be rougher or contamination higher. Placing a lightweight mesh behind the fascial closure at the index operation can significantly reduce the chance of a hernia forming later.
Okay. But if prevention fails or wasn't done and an incisional hernia does develop, what about the repair? You said earlier that just stitching the hole closed again, suture repair alone, is basically unacceptable now.
For almost all incisional hernias of significant size, yes. Suture repair alone has recurrence rates that can exceed 50%, which is just not acceptable. Mesh reinforcement is considered mandatory for durable repair of nearly all incisional hernias.
Okay. And the repair can be done open or laparoscopically.
Both are options, and the choice depends on the size and complexity of the hernia, previous surgeries, patient factors, and surgeon expertise. Laparoscopic repair usually involves IPOM placement with composite mesh, while open repair allows for potentially placing the mesh in that preferred subtly extraperitoneal plane, often requiring more extensive dissection.
But when you're dealing with really massive defects, sometimes you can't actually pull the edges of the fascia back together even with mesh. Surgeons have to resort to just bridging the gap.
That's a major challenge in complex abdominal wall reconstruction, yes. When the fascial edges are retracted so far apart that closing them, even with relaxation techniques, would create way too much tension, the surgeon might have no choice but to simply bridge the defect with a large piece of mesh, securing it to the fascial edges around the perimeter.
And this leads to that phenomenon you mentioned called pseudorecurrence.
Exactly. Pseudorecurrence is a key concept here. When you just bridge a large defect, the mesh itself prevents the bowel from actually herniating through the original hole. So technically, the hernia hasn't recurred in the sense of fascial failure. But because there's no solid muscle or fascia supporting the mesh in the center of the bridge, that area of mesh can bulge outwards significantly under normal intra-abdominal pressure. The patient is left with a large, often unsightly, and sometimes still symptomatic bulge. It looks like the hernia is back, even though the mesh is intact at the edges.
So it's not a true failure of the mesh attachment, but a failure of the overall reconstruction strategy.
Pretty much. It highlights the inherent difficulty and the current limitations of reconstructing truly massive abdominal wall defects, where significant tissue has been lost or retracted. Achieving a flat, functional abdominal wall in those situations remains a major surgical challenge.
Wow. Okay, this deep dive has really shown us that the abdominal hernia isn't just one simple thing. It's a whole spectrum of anatomical failures, genetic predispositions, and surgical challenges. Let's try to synthesize maybe the three biggest takeaways for someone listening.
Okay, yeah. I think the first major takeaway has to be discard the simple idea that size equals danger.
Right. Bigger isn't always worse.
Not at all. Hernias represent a whole spectrum of risk.
Yeah.
Those small, tight neck defects like the femoral hernia trapped by that unforgiving lacunar ligament, or that sneaky partial wall Richter's hernia that might not cause obvious obstruction, can be far more acutely dangerous and life-threatening than a massive, wide-necked incisional hernia where things can slide in and out more easily. The rigidity and narrowness of the neck is the critical factor determining strangulation risk.
Okay, that's point one. What's the second big takeaway?
Second, I'd say, the era of one-size-fits-all hernia surgery is definitively over. Treatment has to be highly tailored, highly individualized. Meaning the choice of operation open versus laparoscopic, suture versus mesh, type of mesh, placement plane depends crucially on the specific hernia type: inguinal, femoral, umbilical, incisional. Its characteristics: size, reducible, recurrent. The patient's overall health and comorbidities, their lifestyle needs, and honestly, the specialized skill and experience of the surgeon performing the operation. We've seen that small defects often need mesh just as much as large ones, and high-risk hernias like femoral need specific high-access techniques. It's complex decision-making.
Tailored treatment. Got it. And the third major point.
And third, I think it's the fundamental evolution in how we measure success. Modern surgery, especially with the advent of tension-free mesh repair, has largely conquered the problem of high recurrence rates for most common hernias. That's not the main benchmark anymore.
So the new benchmark is?
The new primary focus, the modern metric of success, is the prevention of chronic pain and the preservation of long-term quality of life. This is what drives the push towards techniques like laparoscopic repair, which generally has lower chronic pain rates, meticulous nerve identification and preservation during dissection, choosing the right type of mesh, lightweight, large pore ideally, and placing it in the optimal anatomical plane, peritoneal sublay when possible, to minimize irritation and maximize comfort.
So it's not just about being hernia-free, it's about being hernia-free and pain-free.
Exactly. And data does suggest that specialist hernia surgeons, those who do these operations frequently and focus on these nuances of nerve handling and mesh selection, consistently achieve better outcomes with lower rates of both recurrence and chronic pain. Experience really matters here.
It's pretty incredible, really, to think about the journey from those early aggressive suture lines that probably inadvertently damaged nerves and often failed because of tension
Mm.
to today, where we're using highly engineered synthetic or even biological materials, placing them in very precise anatomical planes, all guided by this goal of minimizing nerve irritation and maximizing long-term elasticity and function.
It truly is a remarkable evolution in surgical thinking and technology.
Yeah.
And, that leads me to maybe a final thought for reflection for listeners.
Hmm.
Despite all these incredible advances in materials and techniques, despite everything we now know about Bassini, Scholdes, Liechtenstein, laparoscopy, lightweight mesh, biologic scaffolds, we are still, fundamentally, just repairing the consequences of an underlying structural failure.
We're patching the problem, not curing the cause.
Pretty much. We identified earlier that a key underlying driver, maybe the fundamental issue for many patients, is that genetically determined weakness in collagen quality, a systemic tissue problem. So what if the real future of hernia management isn't just a slightly better piece of plastic or a fancier robot? What if it's actually a molecular solution? Are there research pathways being explored, perhaps focusing on ways to stimulate the body to produce more type of collagen, or maybe even using gene therapy approaches someday to correct that intrinsic tissue quality defect at its source?
Could we actually eliminate the risk, make the tissue strong enough in the first place?
That would be the ultimate goal, wouldn't it? To move beyond just repair, however sophisticated, towards true biological prevention, rendering this incredibly common operation obsolete eventually. That's perhaps the most provocative thought. Can we engineer resilience, not just repair failure?